to our respected Associate Dean, Professor Dr. Priscilla Johnson, ma'am, whose guidance has been invaluable in shaping today's sessions. Now, may I request our head of the department, Professor Dr. Muthupradipa ma'am, to welcome the gathering.
Thank you, Dr. Parthasarathi, for beginning this session. And dear participants, I welcome you all. It is such a joy and pleasure to start the season 2 of Physiology Alumni Lecture Series. And as we have mentioned earlier, this is to mark the 20th year celebration of the M.Sc Medical Physiology program that we have been running in the Department of Physiology. I consider myself blessed to have the joy of coordinating the Silver Jubilee of MD Physiology program for the year 2025. And it is additional pleasure to now coordinate the vicennial celebrations of the 20th year of the M.Sc Medical Physiology program. So at this juncture, I would like to thank the management and our beloved Dean, Dr. Balaji Singh sir, for always agreeing to the different kinds of ventures that we want to come across from the Department of Physiology. And my special thanks to my mentor, Senior Professor, Associate Dean Physiology, Dr. Priscilla Johnson ma'am, for supporting us with all our ideas and in particular giving her expertise and guidance to the team that is organizing the workshop for today. And it has been a thorough joy to also work with Dr. Suganya, Dr. Parthasarathi, members of our team Physiology, and one of our fine alumni, Dr. Allen, who agreed to conduct the demo for this session. So best wishes to the three of you for PALS Season 2. And thank you, Divya, for coming up with this beautiful name of Season 2. And shall I add Episode 1? And for this year, we're going to have alternating months of the PALS sessions. And these are going to be workshops. We concentrated on very high thrust theory topics the previous year. And this year, we plan to conduct workshops and hone our skills pertaining to clinical interpretation, explore the diagnostic methodologies available in the Department of Physiology with the help of our M.Sc alumni who have identified a certain skill and who are currently excelling in those areas. So I welcome all the participants and the members of our team. Once again, thank you for placing the trust in us and registering for the program. We look forward to churning interesting and interactive and useful workshops throughout the year for you. So best wishes to the team and happy listening to the participants.
Thank you very much, ma'am, for that warm and exciting welcome. We have an exciting schedule ahead of us today. To begin, Dr. Suganya, Assistant Professor, Department of Physiology, Sri Ramachandra Medical College and Research Institute, will deliver a lecture on the basics of pulmonary function tests, setting the academic foundation. This will be followed by our guest speaker, Mr. Alan Morris, Assistant Professor, IRED School of Health Sciences, who will be demonstrating the practical aspects of spirometer with the setup that we have here. Finally, I, Dr. Parthasarathi, Senior Resident with this department, will conclude today's program with few case-based discussions. Once again, I welcome all our participants, both online and offline, and I look forward to an engaging and fruitful workshop. Now, I invite Dr. Suganya, Assistant Professor, Department of Physiology, Sri Ramachandra Medical College and Research Institute, to start with the presentation on the basics of pulmonary function tests.
Suganya, you should turn your video also on so that we can see you also. Yes, we can see.
Am I audible, ma'am?
Yes, perfect. Yeah, perfect.
Yes. Hello, everyone. This program of
Is it only me or are there audio video glitches?
At the outset, I would like to sincerely thank two persons in the department. Am I audible to everyone?
You're audible, Sugidya, but there are minor glitches for me. I'm not sure if it's because of the internet here. Can other participants give a thumbs up if everything is fine? Okay, Suganya, I think you should continue now.
Yes, ma'am. Yes, ma'am. At the outset, I would like to thank two important persons in the Department of Physiology, Dr. Muthu Pradipam ma'am, Professor and Head of Physiology, and Dr. Priscilla Johnson ma'am, Associate Dean Medical College and Professor of Physiology, who always think about the benefit of the postgraduates and conduct sessions accordingly. And it's their vision, kind of this program is possible today. So once again, I thank sincerely. Thanks, ma'ams. Before we move into the session, I would like to give a brief activity to the participants. I request the participants to take a deep inhalation and close your nostrils partially, but keep it in mind, do not breathe out through your mouth. So tightly seal your mouth, take a deep inhalation, close your nostrils partially, and gently blow out through your nostrils. You can repeat this 2 to 3 times. After this, you can share your experiences to me. The offline participants can also do so. Take a deep inhalation, close your nostrils partially, then breathe out through your nostrils gently. Partially close nostrils gently. The online participants can unmute yourself and you can share your experiences to me. Or you can write it in the chat box. Any responses in the chat box? It's difficult by head of the department. Anybody else?
Suganya, I'll take a second here. Dear
Yes,
participants,
ma'am.
it is very hard to deliver a guest lecture online to participants who are sitting in various rooms across the country. It is unimaginably harder to conduct a workshop online, and therefore, I request all the participants to feel less inhibited, free. And this workshop is primarily to cover the basics. And we have three excellent people who are there to simplify things and present the basics to you. I encourage you to interact and make the most out of the workshop. Over to you, Sukanya. Yeah.
Thank you, ma'am. So as a ma'am said, it's very difficult, and this is the experience the patients with COPD experience during the every breath of their life. Is somebody has responded? Kala is difficult to breathe. Is this is how the patients with COPD experience during the every breath of their life, and I hope this small activity helped you to empathize their breathing difficulties. So let's move into the session. Pulmonary function tests are basically a group of tests, they are not a single test, done to assess the functional status of the lungs, both in physiological as well as pathological conditions. And the PFT provides objective and quantitative assessment of respiratory physiology. Yes, it gives us the measurable and numerical assessment of how a lung functions properly. So we can compare this to the report card of the lung. The pulmonary function test can be compared to the report card of the lung, and the PFT will tell whether the lung has passed or failed, not only tell whether it has passed or failed, but it will tell how the lung has responded in that way. So we can call it as the report card of the lungs. And it is very important to differentiate between the obstructive and restrictive lung diseases. Pulmonary function tests are used to assess various aspects of the lung function like ventilation, perfusion ratio, diffusion, and the effect of exercise. Today's session will be focusing on the tests to assess ventilation, such as static and dynamic lung volumes and capacities. The static lung volumes and capacities, they are not time dependent and they can be measured using spirometry or any special techniques like body plethysmography, etc. Whereas the dynamic lung volumes and capacities can be measured using spirometry. And spirometry is the commonly performed pulmonary function test in the clinical practice. And since it forms the foundation of the respiratory function assessment, today our session will be focusing mainly on the principles, the procedures, the results, and the interpretation of the spirometry results. Before we move on further, I just want to clarify three terms: the spirometer, spirometry, and the spirogram, which are often used interchangeably, but they are not the same. So the spirometer is the instrument or the device used to measure the lung volumes and capacities. The spirometry is the process of measuring the lung function. And the spirogram is the graphical recording what we obtain after the spirometry test has been done. So with this clarity, we'll see what are the lung volumes and capacities that can be measured using the spirometry. As I mentioned earlier, the static lung volumes and capacities, they do not depend on the time and they can be measured when the lung is at rest. So these are the volumes and capacities that can be measured using the spirometry. And this is the spirogram showing the different static lung volumes and capacities. So the tidal volume is the normal volume of air that can be breathed in or out of the lungs during the quiet respiration, and it is around 500 ml. The inspiratory reserve volume is the additional volume of air. So you can see in the spirogram, it is the additional volume of air that can be inspired after the normal tidal inspiration. So this upstroke is inspiration and downstroke is expiration, which is around 2000 to 3300 ml. And expiratory reserve volume is the additional volume of air that can be exhaled out after the normal tidal exhalation, which is around 1000 to 1100 ml. And residual volume is the volume of air which is present in the lungs after the maximal expiration, which is around 1200 ml. And inspiratory capacity is the maximum volume of air that can be inspired after the normal tidal expiration, which is around 3000 to 3500 ml. And functional residual capacity is the volume of air which is present in the lungs after the normal tidal expiration. This is of physiologically this is important because it ensures the continuous exchange of gases and it prevents the lung collapse. The presence of this functional residual capacity prevents the lung collapse. Vital capacity is the maximum volume of air that can be exhaled out following the maximal inspiration, which is around 3200 to 4800 ml. And total lung capacity is the amount of air present in the lungs after the maximum inspiration, which is around 6000 ml. But among these lung volumes and capacities, certain volumes and capacities cannot be measured by the spirometry directly, like residual volume, functional residual capacity, and total lung capacity, because the spirometry cannot measure the amount of air present in the lungs after maximum expiration. So special techniques are needed like body plethysmography, nitrogen washout technique, and helium dilution techniques are used to measure these volumes and capacities. Now is the dynamic lung volumes and capacities. So they are time dependent and then they can be measured during forced breathing. So these are the volumes and capacities under the dynamic lung volumes and capacities. So the forced vital capacity, otherwise known as timed vital capacity, it is the volume of air that can be exhaled out forcefully following a maximum inspiration. So what is the difference between vital capacity and forced vital capacity? Here, the volume of the exhalation is done forcefully. And FEV1 is the amount of air which is exhaled during the first second of the FVC. And FEV1 and FVC ratio, FEV1 by FVC ratio is the proportion of FVC which is exhaled during the first second. And FEF, forced expiratory flow, 25 to 75, or maximum mid-expiratory flow rate, MMEFR, is the maximum flow of the middle third of the forced expiratory flow. This indicates the patency of the smaller airways. And peak expiratory flow rate is the maximum flow rate of the forced vital capacity, and this indicates the status of the larger and central airways. The minute ventilation, which is otherwise known as respiratory minute volume, it is the volume of air which is inhaled or exhaled in 1 minute, and this indicates the gas exchange status of the lungs and overall lung functions. The maximum voluntary ventilation, otherwise known as maximum breathing capacity, is the maximum volume of air that can be exhaled out by maximum voluntary effort. This indicates the endurance of the respiratory muscle. And breathing reserve is the volume of air which can be inhaled or exhaled above the minute ventilation. This also indicates the endurance of the respiratory muscles. So hope you understood the static and dynamic lung volumes and capacities, their definitions, and the significance in the lung functions. So by measuring these lung volumes and capacities, the spirometry is used to detect the disease and serves as a diagnostic tool. It evaluates the severity, extent, and monitor the course of disease. It will check whether the treatment strategy is working out or not. It is used to assess the risk for surgical procedures, check for the post-anesthetic lung complications, and it will measure the effects of the occupational and environmental exposures, and it can be used for research activities, the effect of intervention on lung volumes and capacities. So in our department, we use COCO spirometer because it is quick and easy to use. It is user-friendly, reliable, accurate, cost-effective, and efficient. And it is best suitable for industrial purposes, especially for the large-scale studies. Many of our postgraduates and faculties have benefited by using this for the large-scale studies. The tests and parameters measured using the COCO spirometer are forced vital capacity test, forced vital capacity test, which measure most of the parameters of the dynamic lung volumes and capacities, such as FEC, FEV1, FEV1 by FEC ratio, PEFR, and FEF 25 to 75. And slow vital capacity test measures tidal volume, inspiratory capacity, and vital capacity. The maximum voluntary ventilation test will measure the maximum voluntary ventilation, otherwise known as maximum breathing capacity. And pre and post bronchodilator tests can be done, reversibility tests can be done using the spirometry to differentiate between asthma and COPD. So the prerequisites for spirometry, ask the patient not to smoke at least 1 hour before the test, because the smoking can irritate the airways and it can cause bronchospasm and may alter the lung functions. And drinking alcohol for at least 4 hours should be avoided before the test because it can suppress the central nervous system and may affect the respiratory function. And ask the patient not to exercise heavily for at least 30 minutes before the test, because it can increase the respiratory rate and increase the sympathetic tone, and hence the respiratory functions also gets altered. And make sure that the patient do not eat large meal for at least 2 hours before the test, as it may affect the lung function. The gastric distension may decrease the expansion of the lungs. And wearing tight cloth also may decrease the expansion of the lung. So make sure that all these prerequisites are fulfilled before moving on to the spirometry test. Procedure for spirometry. Make the patient to sit comfortably. Then wear the nose clip. The nose clip is not mandatory. They can close their nostrils with their fingers. And breathe on the mouthpiece. The mouthpiece is attached to the spirometer. Then ask the patient to breathe on the mouthpiece. Ask him to take a deep breath as fast as possible. And ask him to blow out as hard as possible. Repeat the maneuver until you get the 3 acceptable curves in the spirometry test. And make sure that there are no coughs, there are no air leaks, and there are no false starts. There should not be any hesitations during the expiratory flow. And repeat the maneuver to a minimum of 3 times, and a maximum of 8 attempts is acceptable practically. And then check for the reproducibility. So since spirometry is purely effort dependent, ask the patient to blow out longer, blast out faster and order. So now you may wonder, what are the acceptable curves? What is reproducibility? Acceptability is nothing but how well the test is performed according to the standardized criteria, standardized acceptability criteria. So it means whether the patient has made a good effort and whether they have done the technique properly. So that is said to be the acceptability. Reproducibility is whether the test results are consistent across multiple attempts. And these are the standardized acceptability criteria. There should not be hesitation or any false starts during the expiratory flow. So make sure that there should not be any hesitation or false starts during the expiratory flow. And the volume of back extrapolation must be less than 5% of FVC or 150 ml, whichever greater can be taken. So what is volume of back extrapolation? It is extending the expiratory slope backwards to find out the actual zero time of the expiration, beginning of the expiration. So see here, this is the graph of the volume time curve. So this is the expiratory slope. So the backward extension of the expiratory slope to find out the actual zero time of the starting of the expiration, maximum expiration, is said to be the back extrapolation. So this volume should be less than 5% of the FVC or 150 ml, whichever greater should be taken. So hope you understood about the back extrapolation. I repeat again, it is the backward extension of the expiratory curve in the volume time curve to find out the actual zero time of the expiratory flow, beginning of the expiratory flow. And they should not, make sure there should not be cough or hiccups during the first second of expiration. And there should not be glottis closure, no leaks, no extra breaths. And make sure the mouthpiece should not be obstructed by the tongue or the dentures. And the plateau in the volume time curve should be achieved in at least 6 seconds. So always encourage the patients to exhale for 6 seconds. So these are the acceptability criteria should be fulfilled by the patients to get the acceptable curves in the spirometry test. So a minimum of 3 acceptable curves should be obtained to get an ideal spirometry result. The predicted normal values for spirometry should be ethnically appropriate. So ethnical appropriation is very important because basically our South Asian population, they'll be having a low average lung volumes. So if you're going to compare the actual value of South Asian population to the predicted value of Caucasian population, basically they are Europeans, so you'll get a false low results. So ethnical correction should be done before you start the test. And in the spirometry result, you can see 3 values. 3 values will be displayed. One is the observed value, the next one is the predicted value, the next one is the percentage predicted. Observed value is the actual value recorded from the patient. Predicted value is the expected normal value for a healthy person having the same age, sex, height, and ethnicity. Percentage predicted is the patient's measured value as a percentage of the predicted value. Here is a given example. So FVC and FVV1, the observed values and predicted values are listed here. So see here how they have calculated the percentage predicted. So you can divide the FVC by FVV1 ratio of the observed and the predicted values and multiply it by 100. So observed value of FVC divided by the predicted value of FVC into 100 gives the percentage predicted value. So this is the graphical recording of the forced vital capacity test done using the cocospirometer. So on the left side, you can see the flow volume loop. On the right side, you can see the volume time curve. So the flow volume loop, it tells the relationship between the volume in liters in x-axis and flow in liters per second in y-axis. Whereas the volume time curve tells us the relation between the time in seconds and volume in liters, time in x-axis and volume in y-axis. And you can see the values here. The parameters FVC, FEV1, etc. are shown here. This is the actual value. The one which is in the center with the green tick is the actual value. And the one on the left side is the predicted value. And this is the percentage predicted. So for better understanding, let me move on to the graphical representations of the flow volume loop and volume time curve. So this is the flow volume loop of the forced vital capacity test obtained using the spirometry. So you can see here, below this horizontal line is the inspiration phase. Above the horizontal line is the expiration phase. And this forced vital capacity test is basically making the patient to take a deep inspiration, then asking them to blow out as forcefully as possible. So when the patient takes a deep inspiration, at the end of inspiration, which is said to be the total lung capacity, TLC, then when the patient blows out forcefully, the peak of the forceful expiration is said to be the peak expiratory flow rate. And initially, this is effort dependent, and the steep is effort dependent, and later on, the flow gets reduced. This is effort independent, and at the end of maximum expiration, the amount of air remaining in the lungs is said to be the residual volume. And see here, the volume is represented in liters in x-axis and flow is represented in liters per second in y-axis. Hope you understood the flow volume loop. I repeat again. So the phase below the horizontal line is said to be the inspiration. Above the horizontal line is said to be the expiration. So at the end of maximum inspiration, deep inspiration, the volume remaining in the lungs is said to be the total lung capacity. Then the patient is asked to blow out forcefully. So the end of the peak expiratory flow rate, you can see here. Then the expiration gets slowed down, and at the end of expiration, the amount of air present in the lungs is said to be the residual volume. And almost 80% of the air is blown out during the first second of the forced vital capacity, which is said to be FEV1, forced expiratory volume in 1 second. So 80% of the air should be blown out during the first second of forced vital capacity. And in this picture, you can see the different levels of the forced vital capacity test. This early phase of forced expiratory flow rate, that is 25% of forced expiratory flow rate, indicates the patency of the larger airways, whereas the middle and the late phase indicates the smaller airways. And this is the volume time curve. The volume time curve exclusively shows the expiratory flow rate. So this is the expiratory phase of the forced vital capacity test. And here, you can see the FVV1. At the end of first second, 80% of the forced vital capacity should be expelled out, and the plateau should be attained at the 6th second of the forced vital capacity test. So this plateau at the 6th second indicates a good reliable curve. In conditions like obstructive lung diseases and restrictive lung diseases, especially in obstructive lung diseases, this plateau, obtaining this plateau may get delayed. And in restrictive lung diseases, mostly the curve will be in the normal shape, but the height will be reduced because of the problem in the expansion of the lungs. But in the previous image, you can see there is a slight negative deflection. Actually, this should not occur in an ideal curve. This may be due to mild hesitation or any artifacts. So the volume time curve always should have the expiratory curve, and the plateau should be attained at the 6th second. So the key spirometry parameters are forced vital capacity, FEV1 and FEV1 by FEC ratio. So forced vital capacity is the volume of air which can be exhaled out forcefully following a maximal inspiratory effort. And majority of the FEC is exhaled within 3 to 4 seconds. It is measured in liters, and in males it is 4 to 5 liters, and in females it is 3 to 4 liters. FEV1 is the volume of air which is exhaled during the first second of the post vital capacity. And for normal people, it should be equal to or more than 80% of the FEC. It is also measured in liters. In men, it is 3 to 4.5 liters, and female, it is 2 to 3.5 liters. And the ratio, FEV1 by FEC ratio, is the proportion of FVC, which is exhaled in the first second. It is a critical indicator to differentiate between the obstructive and restrictive lung diseases. This is the pulmonary function test report obtained using the COCO spirometer. So here on the top, you can see the patient information, which has name, patient ID, date of birth, height, weight, sex, age, even the smoking history is asked, and the ethnic correction should be done. And it also includes the physician who is attending the patient and the technician who is doing the test. And the results are shown here. So this is the actual measured value from the patient, and this is the predicted value, and this is the percentage predicted value. And at the bottom of the report, you can see the flow volume curve and the volume time curve. So let us see the effect of spirometry in identifying the lung disease and differentiating the obstructive and restrictive pattern of lung disease. Basically, we can categorize the lung disease into 3 types. The diseases that affect the airways, they are said to be the obstructive lung diseases, such as asthma, COPD, bronchitis, etc. The diseases due to the damage of the lung tissue affecting the inflow of the air. This includes especially the expansion. This includes pulmonary fibrosis, sarcoidosis, etc. And lung circulation disease, where the blood flow from and to the lungs will be affected. This includes pulmonary hypertension and pulmonary edema. So let's see what are obstructive lung diseases. Obstructive lung diseases are basically a group of disorder where there is an obstruction to the outflow of the air. So as a result, the air gets trapped inside the lungs. And these are the diseases where the obstruction is seen. In asthma, you can see a hypersensitive airway. The airway will be irritant. And here, the obstruction is reversible when compared to all other obstructive lung diseases. COPD is mainly because of the chronic exposure to the toxins due to smoking, etc. And bronchiolitis is the inflammation of the terminal or respiratory bronchioles, mainly due to viral infection, and this commonly affects the children. And bronchiectasis is the permanent dilatation of the airway due to chronic infection like pneumonia, post-tuberculosis, etc. And cystic fibrosis is the autosomal recessive disorder. It's a genetic disorder where you can see there is an excessive formation of the mucus leading to chronic infection and inflammation. So in all these diseases, there is a obstruction to the outflow of the lung. As a result, there will be trapping of the air in the lungs. Now coming to the restrictive lung diseases. Restrictive lung diseases are basically categorized into two types, parenchymal and extraparenchymal. Parenchymal restrictive lung diseases, the problem is with the primary lung tissue, whereas in the extraparenchymal restrictive lung disease, the structures surrounding the lungs will be affected. So here in the parenchymal restrictive lung disease, the fibrosis is due to either irradiation or any occupational exposure or idiopathic. The cause is not known. Whereas in the extraparenchymal restrictive lung diseases, the diseases affecting the chest wall, such as kyphoscoliosis, neuromuscular disorders, trauma, and diseases affecting the pleura, such as pleural effusion, pneumothorax, and even severe distension of the abdomen can affect the expansion of the lung. So basically, in restrictive lung diseases, the expansion of the lung is affected. The inflow of the air into the lungs is difficult. Whereas in obstructive lung diseases, the outflow of the air from the lungs is difficult. Now let's see the interpretation of FEC test in obstructive and restrictive lung diseases. As per the Indian guidelines, Indian Chest Society, National College of Chest Physician, the FVC and FEV1 should be more than or equal to 80% of the predicted value is considered to be normal. Our Indian consensus are consistent with the American Thoracic Society and European Respiratory Society. So according to them, FEC and FEV1 should be more than or equal to 80% of the predicted value. And here on the left side, you can see the flow volume loops of a normal person, of patients with restrictive lung disease and patients with obstructive lung disease. So here you can see the FVC is 4 liters in a normal person. In the obstructive and restrictive pattern, the FVC gets reduced. But you can see a well-marked reduction in the restrictive pattern of lung disease when compared to the obstructive pattern of lung disease. And the FEV1. The FEV1 here in the restrictive pattern of lung disease is reduced, and obstructive pattern of lung disease, it is well marked. And the ratio between the FEV1 and FVC, you can see a proportional decrease in the FEV1 and FVC in the restrictive pattern of lung disease, whereas here it is not proportional. The decrease in the FVC is mild when compared to the FEV1. So as there is a proportional decrease in the FEV1 and FVC, here the ratio will be reduced, whereas the ratio will be normal or slightly increased in the restrictive pattern, whereas in the obstructive pattern, the ratio will be reduced. So here, there is a proportional decrease in the FVC and FEV1. As a result, the ratio remains normal, though FEV1 and FVC showed a marked reduction, whereas in the obstructive pattern, there is no proportional decrease in the FVC to FEV1. FVC reduction is mild when compared to FEV1. So the percentage is reduced. So I think we can better understand with the numbers. So here are the values for the FEV1 and FVC. So for a normal person, it is 4 liters, FVC is 4 liters, and FEV1 is 3.2 liters. And the ratio of FEV1 by FVC is 80%, which is said to be normal according to Indian guidelines. In the obstructive pattern, you can observe the reduction in the FVC, but not well marked as compared to the FEV1. And see the ratio, it is well reduced. Whereas in the restrictive pattern of lung disease, you can see reduction in both the well-marked reduction in both the FVC as well as FEV1. Since it is proportional to each other, the ratio remains normal or Sometimes it may be elevated. I've shown you the another set of value where you can see the increased in the ratio of FEV1 and FVC. So again, the flow volume loops of obstructive and restrictive pattern, reinforcing again, there is a proportional decrease in the FEC and FEV1 is in restrictive pattern of lung disease, and there is a disproportionate decrease in the FVC and FEV1 in obstructive lung pattern. And this is the flow volume curve. Sorry, this is the volume time curve of a normal person. And this exclusively shows the expiratory slope. And here, FEV1 is the volume of air exhaled out during the first second. So almost 80% is exhaled out because the FVC here is 5 liters. So FEV1 is 4 liters. So 80% of the FVC is exhaled from the during the forced expiratory flow rate. So FEV1 by FVC is 0.8, which is normal. Whereas the volume time curves of the obstructive and restrictive lung diseases, you can see the forced vital capacity gets reduced because here there is an obstruction to the outflow of the air. And the plateau is obtained almost at the 6th second. But here in the restrictive pattern, you can see the curves almost look similar. The normal curve as well as the restrictive pattern curve looks similar. But see the height of the curve. The height of the curve gets reduced because there is a problem in the expansion of the lung. So here, since there is a problem in the outflow, the FVC gets reduced. And since here there is problem in the expansion of the lung, the height of the curve gets reduced. So here are a few key points. So in obstruction, there is a limitation to airflow. Mixed condition, mixed type of disease, you can see the features of both. And the causes were explained already. And in a mixed pattern, COPD with pulmonary fibrosis, bronchiectasis with fibrosis can have this pattern of disease. And the values FVC key parameters, FVC, FEV1 and the ratio. In obstructive disease, it is reduced. Both are reduced, but the FVC reduction is mild and the ratio is reduced as a result. Whereas in the restrictive pattern, there is a well-marked reduction in the FVC as well as in the FEV1. There is a proportional reduction among these two parameters. As a result, there's a normal ratio or increased ratio. In the mixed pattern, FVC and FEV1 both are reduced, but still the ratio remains low because of the coexisting obstruction. So another test called as bronchodilator reversibility test can be done using the spirometry. So you can see the flow volume loop before and after using the spirometry bronchodilators. These are the commonly used bronchodilators for the reversibility test: salbutamol, alpha adrenergic agonist, beta adrenergic agonist. Terbutaline is the commonly used bronchodilator in the pulmonary function test laboratory, and ipratropium is found to be effective when compared to the other two bronchodilators. And as I said earlier, our Indian conscience is consistent with the ATS and ERS guidelines. The improvement in the FEV1 or FVC more than 12% or more than 200 ml is the indicator for reversibility. And according to the ERS guideline, improvement in the percentage predicted value of FEV1 more than 10% indicates the reversibility. So if there is reversibility, then it indicates the presence of asthma. If there is no reversibility, then it indicates the presence of COPD, since asthma is a reversible condition. So we came to the end of the session. So before concluding, I would like to summarize the key learning points. The pulmonary function test is a group of tests. It's not a single test. And it is objective quantitative assessment of the lung function. And spirometry is the most commonly performed pulmonary function test in clinical practice. And the key parameters are FVC, FEV1, and FEV1 by FVC ratio. In the obstructive disease, the ratio will be decreased. In the restrictive disease, the ratio will be normal or remains elevated because of the proportional decrease in these two parameters. And accurate interpretation requires proper technique, acceptability, and reproducibility criteria, and it should be ethnically appropriate. So whenever you perform the FVC test, check for the acceptability criteria, whether the patient is undergoing standard acceptability criteria. If yes, look for 3 acceptable curves. If yes, then check for the reproducibility. If any of this is not fulfilled, please repeat the test again. Then finally take the maximum values, save and interpret the results. To conclude, when you are reaching the steeping of this workshop, please interpret the curve with the basic knowledge of spirometry, what you obtained in the past 20 minutes to half an hour session. Thank you all.
Participants, please wait for a few minutes by the time they would settle down for the demonstration.
Thank you, Suganya ma'am, for that insightful presentation. Building on those concepts, we will now move on to the next session, that is a practical demonstration. I invite our guest speaker, Mr. Alan Morris, Assistant Professor, IRED School of Health Sciences, Chennai, to take us through the demonstration with the setup that we have here.
Partha, can you also stop sharing the screen? Yeah, and we can pin the screen where Alan is going to do the demo. Yeah, all the other devices that are there in that room, please ensure that your audio output is off so that we do not have any issues. Yeah. Alan, if you're good to go, you can start.
Yes, ma'am. So, good morning, everyone. I'm Alan, and it gives me immense pleasure to do the demonstration on spirometry. So, I would like to have a few slides regarding this. This video. Okay. Can we just do one adjustment on the light or should I do that? Yes, sir.
Actually, it's clear now. The screen is clear. It's fine. It's fine. Yeah.
So, PFT, spirometry, they are used interchangeably. Spirometry is a specific and the core essential of PFT, which measures the airflow. And all spirometry is PFT, but not all PFT is spirometry. So, why PFT is different? Consider a patient is going to the hospital and he needs to get his diagnostics done. He needs to have a chest X-ray, MRI, or a blood work. In all these, the patient is passive. He doesn't do anything or contribute anything. The patient is being positioned, electrodes or the scan happens, and the report is generated. Whereas in PFT, this is not a passive process. The patient is part of the test and contributes to the valid data throughout the test. Effort and psychology. This is purely effort dependent, and the patient's mindset contributes greatly to the data. So it depends on the understanding of the procedure, the motivation by the technician, and also coordination between the patient and the technician. A motivated technician always gives valid data. He takes the good data from the patient, and also the flow is that the process starts from the technician, goes through the patient, and the patient's lungs obey the command, and finally we get the graph. So the indications and contraindications have been discussed earlier. I will skip that. And what are the pre-requirements? The pre-requirements for the test, even before the patient enters the room, the equipments have to be prepared, ready, and all the necessary accessories. So we have the cocospirometer. This is a handheld pneumotac. This is a portable device which can be taken to field or set up in small clinics. This is connected to a laptop. The laptop hosts a software which measures the pressure and flow changes in the pneumotac and converts it into valid data. So the pneumotac has to be calibrated. So this is the calibration syringe. It's a 1 liter calibration syringe. Before each procedure or before starting the procedure for each day, the pneumotac has to be calibrated and the calibration reports have to be kept safe. So also we have the mouthpiece. The mouthpiece and the nose clip, these are all disposable. The mouthpiece has a filter inside it. It's called the BV filter. This prevents the transmission of pathogens and virus from the mouthpiece to the equipment. And also, before the patient even comes, the patient has to be instructed clearly of the procedure. Smoking has to be avoided 1 hour. The food intake should be avoided 2 hours. Strenuous exercise should be avoided, and also the patient shouldn't be wearing any loose clothing. Shouldn't be wearing any tight clothing. He has to be shifted to loose clothing. Patient positioning. I would like to invite my subject, Mr. Pranesh. For getting the valid data, patient positioning is very much important, and usually spirometry is performed in a upright seated position with their feet flat and planted on the ground and also legs uncrossed. The chin should be slightly elevated with the nose clip and the nose clip. Actually speaking, the spirometry results are better and also slightly increased when the patient is in standing position. But continuous breathing effort can cause dizziness and it might compromise on the safety of the patient. That's the reason all the guidelines suggested a seated and upright position. For spirometry, we have 4 maneuvers, which is maximal and deep inspiration, explosive expiration, and sustained emptying for 6 seconds or more than that, and again accompanied by maximal and deep inspiration. Here we will be performing the FEC maneuver on our subject. Effort, acceptability, and reproducibility. What are these concepts? Effort is a proper maneuver which is done correctly. So the subject has to seal his lip tightly. Now let me use the mouthpiece. While using the mouthpiece, we are instructed, the patient should be instructed so that false values don't enter. The mouthpiece should be placed under the tongue, gripped by the teeth, and sealed by the lips. The chin should be a little elevated and nose clip to be placed. Throughout the spirometry procedure, the breathing should only happen through the mouth. Acceptable efforts consist of a tight seal of the mouthpiece, maximal and deep inspiration, forceful expiration, which is prolonged, and again a maximal deep inspiration. Cough, hiccups are to be avoided in the first second. A maximal of 3 acceptable efforts is required to generate a proper report. Also, in a session, maximum of 8 attempts can be made, beyond which patient inconvenience should be considered. Within each effort, there should be a gap of 30 to 60 seconds. The predicted values are based, as already discussed, on the age, sex, height, weight, and ethnicity. Many predicted forms are considered. For purpose of this software, the Knudsen predicted is used with the correction of 13%. But modern standards have been adopting Z-scores for more accurate data. Now we'll go into the software. We shall enter the patient's information. Previous to that, we'll have to explain the procedure to the patient in his native language and also get the consent. Hello, I'm Alan, and today we'll be checking your lungs. You are expected to breathe in and breathe out in certain instructions which I say. Do you consent to this procedure? Yes. Okay, thank you. I'll be requiring your name, Ganesh. Your surname? The date of birth? Height? Weight? Any history of smoking? Here you can see I'm using the Knudsen's predict. Once entered, I'll be able to perform the FVC test. You can see we have the flow volume loop and the volume time curve. Here you can see pink dots. These are the predicted values which have been calculated by the software on entering this height, weight, and other details. Need to inspire deeply and expire forcefully. Okay, till I take. You should not inspire till I take. Then once I predict, you'll have to again inspire. For more clarity, the procedure can be demonstrated once. Place your mouthpiece. Seal it with your lips. Okay. Take a deep inspiration and forcefully expire for around 6 seconds. Do not inspire during this period. I'll be guiding you. And once you do, inspire. Okay. Yeah. Yeah. Expire. Yes. Okay. So it will be like this.
Please hold on, Alan, because we'll try switching off the lights so that the graph can be seen a bit more clearly.
Okay, ma'am.
And also the participants can try to zoom the Gmeet screen itself in case you want to take a closer look at the graph. Please go ahead. Yeah.
So Don't press it. I'll just show it. I'll demo it to you once. Okay. Seal it tightly. Deep inspiration. You will have to blow out as if you are blowing a candle from up. Okay. It shouldn't be gradual. It should be fast and hard. Okay. Okay. It should be in one single motion. You should inspire and expire. Okay. Right? Can we do it? We'll just do it. Right? Loosen your shoulders. Inspire deeply. Expire. Fully. Keep going, keep going, keep going, keep going, keep going. Inspire. A common mistake which happens over here is the patient loses posture. If you can see, while expiring, he bent forward, moving out of posture, and also he had inspired in the middle. So, keep it simple. I'll tell it to you again. Okay. Look at my. Okay. Deep and quick inspiration, forceful expiration for 6 seconds until I tell you to, and then again a deep inspiration. Okay. Do not move out of posture. Relax your shoulders. Okay. Here. Yeah. We'll do it. Inspire deeply. And this is the incentive graphic. It is used to motivate the patients visually. We understand the graphs, but the patient understands these incentive graphics and motivates them. Yes, sir. Inspire deeply. Expire. Keep going, keep going, keep going, keep going, keep going. Inspire. Okay. Subject motivation is of high priority here. Only with that, good flow volume loop will be obtained. We shall try once. Inspire deeply. Expire. Keep going, keep going, keep going, keep going, keep going, keep going. Okay, inspire. You can take rest a little bit. Take a little water. Rest and gap between efforts is also essential to get a good graph. You can see here there is the grading for the report. So out of the 2 efforts recorded, 2 efforts have been acceptable, maintain the criteria, and also the reproducibility is there. We need another 1 more effort for the procedure to complete. Rest it. Loosen the shoulders. Okay. Inspire. Expire. Keep going, keep going, keep going, keep going, keep going, keep going. Good, good, good. Inspire, inspire, inspire. Okay, thank you. So we have obtained 3 acceptable and 3 reproducible reports with a grade A. So this concludes my demo. Additionally, I would like you to show. You can see the recent flow volume loop. Once the procedure is completed, necessary measures should be taken to prevent cross contamination. With this, I conclude the demonstration. Thank you all.
Thank you, Mr. Allen, for that very clear and engaging demonstration. We shall move on to the final session of the day, where we put all this into the context with few case-based scenarios. As we go through the cases online, I encourage the participants to actively engage, to answer their answers or give their answers in the chat box, or you can unmute your mic and give away your answers also. I'll be sharing my screens with you guys now.
Partha, are you? I can't hear you. How about the others?
Is it audible now?
Okay, thank you, Yogesh sir. I hope Partha is audible to others.
Yes. Okay. We'll begin with our next and final session, few case-based scenarios. Before starting a few cases, I'd just like to refresh your memory of what Suganya ma'am and Mr. Allen has taught you guys. So online participants and offline participants, feel free to give out answers, right? So what is in the x-axis? So here is a flow volume loop, which is normal, like we don't have any abnormalities here. So in the x-axis, we have the answer is volume in liters, right? And in y-axis, we have our, any answers, offline participants? We have our flow, right? That is in liters per second. So we have volume in x-axis, which is represented in the unit liters, and in the flow, that is your liters per second, right? So as we have seen in the demonstration, yes, just a minute, participants.
I think it is an issue of the particular person because I'm able to see the picture.
Okay. Yes.
Also, you have a picture-in-picture of your Gmeet on the slide. You can close that. Yeah, done.
Yes, I hope now it is clear.
Yeah.
For all the participants. Yes. So just now we have seen how this flow volume loop is made in the demonstration, right? So the above part of the curve where the loop where the upper part is going in this direction from left to right, right? So that is your expiration, and the below part of the curve where it is going from right to left is your inspiration, right? So just refreshing your memories about which is what. And I also want to make clear of one more concept. Like this is an example from one more spirometer software, Spirotech software that we have. You can clearly see here that we have 0 at this in the x-axis, and it is going. Few of the textbooks and few other spirometer softwares will not start at 0, but we have the same loop. This is just, both are mathematically same data, but the axis is oriented. Now, before we ask the subject to expire, right? We ask him to inspire to the maximum, right? So at this point, I hope you guys can see, just a minute, I'll open the pointer. Yes. At this point, the subject is fully inspired. So this would be, or the subject will be at his maximum lung capacity. So this point will be your total lung capacity, and this will be his peak expiratory flow rate. the maximum flow rate. This will be it. And gradually, when he expires for 6 seconds, he will have expired all the air but the residual volume. So normally in a static volume, static lung volume, this will be your vital capacity. Hence it is time here it will be your forced vital capacity, right? I just want you to make aware of the graph, which is axis is the differently oriented. Instead of starting from 0, it starts with the total lung capacity and goes to the residual volume, right? With that information, let's move on to the data that has been recorded. So we have all these parameters: dynamic lung volume, FVC, FEV1, FEV1 by FVC ratio, and the maximum mid expiratory flow rate, that is your FEF, 25 to 25%, 75%, and UPFR in your right column, left column. And we have your predicted values, which are the values that after we input our subjects details, we get our predicted values and the best observed values second, and then we'll have your percentage predicted of this predicted value, how much percentage the observation is. Then to make a note, we have our bronchodilator results here. So the subject is given a bronchodilator, or the patient, rather a patient is given a bronchodilator, and after given the bronchodilator, we are asking the subject to, we are subjecting the patient to once again this test. So we get some more values, right? And the last column is how much improvement is happening. So that is the percentage change, or how much ml or increase in FVC that has happened after giving your bronchodilator. This will help in our case resolution, right? Now, from this data, today we'll focus only on this 3 parameters, or mainly this last parameter, which is your FEV1 by FVC percentage. That is your ratio, right? So in obstructive lung disorder, it is decreased, right? Which is almost or more less than 80%. In restrictive lung disorder, it will be either normal or increased. So the takeaway point is low ratio of FEV1 by FVC in obstruction and normal or increased FEV1 by FVC in restriction. I also want to make a note that FVC, right? So it may be normal or reduced in obstructive lung disorder, but in restrictive lung disorder, FVC will always be reduced. So make a note of that also. With that knowledge, we'll move on to the first case. Here is a case of a 19-year-old female who complains of severe cough and shortness of breath. There is a past history for treatment for wheeze, and there is also a family history of allergy. Now, chest X-ray revealed hyperinflated lungs and prominent bronchovascular markings. So with this history, we can assume or we can come to a diagnosis. So the supporting spirometer readings are. Now, the same parameters that I've listed here, I want you to focus on the FEV1 by FVC ratio. So the predicted is 80, but we have 80%. But the best report that the patient gave or observed was only 54%, right? And also look the feature in the curve, right? We have a coved feature or the scooped feature, so which is a distinct signature of your obstructive lung disorder, right? Now, I want you to look at post bronchodilator value. It has been, the FEV1 has increased from 1.9 liters previously before bronchodilation to 2.3 liters. That is an increase of about 21%, which fulfills the criteria for making or diagnosing it as an asthma case. So this is a case of obstructive lung disorder, particularly bronchial asthma. The supporting points are the increase in the change in percentage change, the reduction in the FVC in the FEV1 by FVC ratio, and the scooped out curve in the flow volume loops, right? Now, when we go on to the next case, a 45-year-old male who is a non-smoker working in a cement factory presents with exertional dyspnea, dry cough, and fine inspiratory crackles on auscultation. His X-ray showed nodular opacities. The spirometry readings and the flow volume loop are this. Now again, you can see that FEV1.
Sorry
Yes,
to
ma'am.
interrupt. Could you just give them a minute to read the values, and can they
Yes.
try answering? Yeah, if you don't mind. Sorry.
Yes.
Yeah, anybody from the
Yes.
audience, could you just try
Yes,
answering?
the offline participants and the online participants can go through the values that are displayed, and we can also look at the flow volume loops, the characteristics of the loops.
can unmute and probably give the answer. Yeah.
Yes, that is the correct answer, restrictive disease. And the supportive points for the restrictive disease is mainly the first point is your ratio, where FEV1 by FVC ratio is increased, right? It is more than 80%. And you make a note on FVC also, right? I told you previously, FVC also will be severely reduced in restrictive lung disorders, right? Now, take a look at the loop here. The FVC is reduced and the total lung volume will also be reduced. Now, here is one more example picture of restrictive lung disorder. Here is your reference graph or the predicted upper part, the expiration curve of the flow volume loop. And here is the observed loop. You can see the total lung volume is also reduced and your residual volume also reduced. So giving it as a classical picture of your restrictive lung disorder. With the history of working in the cement factory, silica exposure, this is a silicosis diagnosis, right? Now, we'll move to the last case for the day. A 60-year-old man who is a chronic smoker presents with cough and occasional wheeze. He also complains of severe breathlessness, which is aggravating during climbing stairs and walking. His X-ray showed hyperinflated lungs, right? Now, here is values. I give 1 minute for the participants, both offline and online. I encourage online participants to type the answers in the chat box or unmute the mic and give away the answers also. Make a look at the ratio. You can look at the bronchodilator change also, and also take a hint from the curve also, the loop, flow volume loop. What is the answer? Abstraction. How will you support your answer? Ratio, right? The ratio is reduced. It is 60%, right? Here 0.60 is given, but it is in 60%. And the second clue is the coved out or the scooped out part of your flow volume loop, right? And the third supportive diagnosis, that to differentiate it from asthma, right? We have a chronic smoker. So he is a chronic smoker, right? So this is a diagnosis of chronic obstructive pulmonary disorder, right? Obstructive lung disorder here, which will not be improved on giving a bronchodilator. So this won't be reversed. The bronchodilator reversibility criteria is not fulfilled here. The improvement is only 8%. We have learned that it should be at least 12% or 200 ml in FEV1, right? So it is not improved. So we can say that it is the patient is suffering from COPD, right? Now, we have come to the conclusion of the workshop. I would once again like to thank our head of the department, Professor Dr. K. Muthupradipha ma'am. So I invite her to share a few words with us as we conclude this session.
Thank you, Dr. Partha, for giving me an opportunity once again to talk to the participants. Thank you, participants. It will be really nice if you could, shoot your comments. They will be, yeah. Okay, so Partha, can we hold it at this slide? Yeah. Could you shift to the slideshow mode? Yeah, thank you. So thank you, Dr. Sukanya, Dr. Partha Sardi, and Alan for putting up this great show together. There was a lot of preparation and a good amount of coordination and work that happened. So, as far as Suganya is concerned, she is this dependable, strong pillar of support in the department. So, and I personally, sentimentally felt that she should be the first person to start off the skill-based workshops for the PALS Season 2. And Dr. Partha Sardi, I think he's only with us probably for a month or a little more or a little less. He recently joined as a senior resident, and we found that his thesis topic revolved around pulmonary function tests also. And the name Scoop to Steeple was his idea. And being a new person, I think he has gelled very beautifully with the team. And it's so amazing to see you whip up the cases and perform well. And Alan, he is a very recent pass out. A few months ago, he completed his M.Sc Medical Physiology from our department, and his pedagogy performances was one of the most appreciated by the external examiners. So all that I had to do was to put these three people together and decide to do the workshop, and such a beautiful outcome has happened today. And thank you to the participants once again for staying through the entire 1.5 hours, listening to the first lecture and then to the demo and then to the case resolution also. So we have Dr. Suma with us as an audience during this session, and I'm so excited to invite her and pulmonologist Dr. Shweta from Savita Medical College for the next session in the month of February, third Saturday, February 21st, where they will go one step further and discuss more cases coming back to the relevant physiological aspects of the pulmonary function tests and the diagnosis of various respiratory disorders. So I encourage the participants to stay tuned to our updates on various social media platforms and sign up for this session. As you all know, we already had Research Toolkit 101, the first session, which was a basic lecture on study designs. We are following that up with on February 25th as an offline, in-person, hands-on workshop on study designs limited to 30 participants, where we will have Dr. Divya Lakshmi and Dr. Parthasarthi co-teaching along with our expert resource person, Dr. Vijay Prasad Gopichandran. So people who are in Chennai and nearby, I urge you to plan this date and be with us for the offline hands-on workshop. I want you to know that many senior people attend these sessions. Thank you very much for your humility. But what I would like to say is these sessions are curated keeping in mind the young PGs, the beginner PGs, and the young faculty in mind. Also, it gives a chance for members of the team physiology and alumni of physiology for showcasing their expertise in various fields. So thank you, participants. Thank you, Suganya, Parthasarthi, and Alan once again. Thank you, Priscilla ma'am, for your wishes. Ma'am, would you like to say a few words if possible? Else, your guidance meant a lot to us in being confident and going ahead with this show. Thank you to the rest of the team of physiology also. May you please project the feedback QR
I
code.
just wanted to congratulate all three. I'm so proud of you guys.
Yes,
Did a great job. Keep it up. And thanks, Pradeep, for organizing it, for cheering up everyone and putting them in the right role.
thank you so much, ma'am. Thank you, ma'am.
So nice to see our mentees perform well. That's what
Absolutely, absolutely, ma'am. And I think, Alan is also Priscilla ma'am's student, and his thesis was on PFT, and it was shining out so brightly today, ma'am.
Alan, you made me feel proud today.
Yes, ma'am. Yeah. Thank you, Pranesh. I forgot. Pranesh is currently a second MBBS student. He passed out from us last year. So, following the footsteps of Suganya, Partha, and Alan, this is another very committed and a dependable student. All
Yeah.
that we had to tell him was to come, and he came and practiced and performed very well. Thank you, Pranesh. We have a nice little book for you as a present. We'll give it to you after the session.
Thanks, Pradesh. Thanks, everyone.
Thank you, people. Thank you, ma'am. The feedback link is posted here. Details about the other sessions will follow in various social media platforms. And Partha, would you like to go ahead and thank you to our MSc postgraduates who are there today, supporting the conduct of the session, watching out for AV glitches. Special thanks to Muthukrishnan. For the first time, he was given the responsibility of video recording the show and especially projecting the demo. So many practice sessions, so many trial sessions, and kudos to the entire team. It is a joy and pride to work with all of you. Thank you, people. Partha, I leave it to you to close the session. Yeah.
Yes, ma'am. Thank you for those beautiful words, ma'am. Now, as we come to the conclusion, I would once again like to thank our head of the department, Professor Dr. K. Muthupradipa ma'am, and our Associate Dean, Senior Professor, Professor Dr. Priscilla Johnson ma'am, whose guidance has been invaluable in shaping today's session. My heartfelt thanks to Dr. Suganya ma'am and Mr. Allen for their excellent contribution to today's workshop, and also to the supporting team, which comprised of our MSc postgraduates, Mr. Pranesh, second year MBBS student and secretary and lab technicians and non-teaching staffs for the smooth conduct of the session. And to all participants, both offline and online, for your active engagement. We hope today's sessions have made your understanding of the pulmonary function tests easy and provided good practical insight. Right? Before we move on from this session today, I request all the participants to switch on their cameras to take one group photo virtually. Yes, can we have them? Yes, everyone. Done. Yes.
All of you can turn the video on so that we can smile for a picture. Come on. Join. Divya, take Anju alone.
Yes, everyone. Smile. Thank you all. We look forward to seeing you in the upcoming academic programs. Before we sign off, I request all online and offline participants to give feedback. There is a feedback link in the chat box, and you'll also receive the feedback form in your emails also. Thank you, everyone. This, I'll close the session.